acute UTIs, you know, looking at up there in the key message, is that saying we're not, GPs aren't treating them adequately enough? Should we be on longer courses? I mean, I understand.
Well, the thing is, I think over time, we have made the courses shorter and shorter.
Yes.
Where did the theory of 3 days of trimethoprim is enough to clear a urinary infection come from? We have absolutely no evidence. So I think in the past, the GPs would prescribe at least 5 or 7 days of antibiotic, but now it's all 3 days of trimethoprim. Majority of our population are resistant to trimethoprim because it's the most commonly used or abused antibiotic. So prescribing antibiotics for a very short period of time when the patient hasn't cleared symptoms is not good.
No.
Secondly, in the past when I used to do, when I used to be a house officer, we would treat a UTI, bring the patient back, ask them to redo the urine sample, dipstick it, and they're still symptomatic. At least within 10 days you're picking it up and giving them another course. But nowadays they just disappear. The patients don't have another appointment. You've got a UTI, 3 days trimethoprim, off you go. You apply to go back to the GP. It takes about 6 weeks to get an appointment for a UTI. You will not get an appointment for a UTI. You can't go to A&E with a UTI because you've just been treated by the GP. And it just becomes a cycle where people are left. And I think primary care has the biggest role over here. And I think if GPs are willing to see their patients, take it a bit further, saying, okay, we'll treat you with 10 days. 5 days didn't work, so we'll treat you with 10 or 14 days of antibiotics. And then revisit the area. It's the lack of follow-up which is causing the problem. And if I think retrospectively, when we look back, like 20 years down the line, if we've been treating it properly right from the beginning, we probably wouldn't have been here. Because the number of UTI cases are increasing. Chronic UTI is actually recognized in every clinic. I have at least 3 patients in a general gynecology clinic or urogynecology clinic. We never used to have this before. So I think we've created part of the problem by reducing, and the antimicrobial stewardship rules are so rigid that even if I prescribe 500 milligrams of cefalexin once daily, they go crazy on you saying, God, that's not a prophylactic antibiotic. Some of the hospitals, you cannot prescribe full dose antibiotic. I cannot give fosfomycin prescription out in my current hospital because it's something that the microbiologists have to clear. So I think as medics, we have become very ingrained with what we know, and the guidelines are getting sort of even more stricter. Most of the guidelines are not evidence-based. Everyone quotes NICE guidelines. If you know exactly what happens with the NICE guideline committees and the level of evidence that comes out, you would probably not follow most of it. And most patients do not fit a pathway or a guideline. They do not fit into boxes. You have to treat them as individuals. And I think that's where the primary care is very important.